This talk is going to be on rheumatologic and autoimmune diseases and CNS vasculitis. So these are the things I'm going to talk about: neurosarcoidosis, IgG4 related disease, lupus, Behcet disease, granulomatosis with polyangiitis, GPA, also called Wegener's granulomatosis, Susac syndrome, autoimmune encephalitis, and CNS vasculitis. Okay, so the first case, 52-year-old woman, 1 week of left eye vision changes and pain. Had MRI. This is coronal T1 post-contrast. A few subtle abnormalities. You can see a little bit of enhancement here adjacent to the optic chiasm. Maybe a little bit of enhancement here next to the cavernous sinus. Another slice shows a more pronounced area of enhancement adjacent to the cavernous sinus. And further anteriorly, we can see more enhancement around the left optic nerve. So this patient has both pachymeningeal enhancement, this lesion along the cavernous sinus, as well as leptomeningeal enhancement along the optic chiasm and optic nerve. Some of the routine brain images show a little bit more leptomeningeal enhancement, a little focus here in the CP angle cistern, maybe a little bit here anterior to the brainstem. You can see over here on the sagittal. Here's this pachymeningeal lesion, and here a couple of foci of leptomeningeal enhancement along the surface of the upper cervical spinal cord. Patient had a CT of the chest, showed bilateral hilar and mediastinal lymphadenopathy. And of course, the diagnosis here is neurosarcoidosis. So we see neurologic involvement in about 10% of patients with sarcoidosis. About half of the patients with neurosarcoidosis have the neurologic symptoms as the presenting manifestation. Although even the ones who present with neurologic symptoms, most of them also have systemic involvement. Before we go any further, I just want to review quickly the meninges, so we can talk about meningeal enhancement. The dura, arachnoid, and pia. Dura is the pachymeninges, the arachnoid and pia are the leptomeninges. When we talk about meningeal enhancement, pachymeningeal enhancement refers to enhancement of the dura, and leptomeningeal enhancement is enhancement of the pia and subarachnoid space. So for neurosarcoidosis, what do we see on imaging? So leptomeningeal enhancement is probably the most common feature. Often it's most pronounced near the base of the skull, especially common around the optic chiasm, pituitary, hypothalamus. We also see pachymeningeal enhancement, like in this case, pachymeningeal enhancement along the cavernous sinus. The pachymeningeal enhancement can be either mass-like or linear, and we also see pachymeningeal enhancement with IgG4 related disease, which we'll talk about later. We can have enhancement of cranial and spinal nerves. This cervical spine shows areas of enhancement along spinal nerves. And we can have parenchymal brain and spinal cord lesions. And the parenchymal lesions tend to be more pronounced along the surface of the cord and then work their way from the surface down into the spinal cord or the brain. And these often, the disease often spreads along prevascular spaces in the brain. Another patient with sarcoid showing a lot of leptomeningeal enhancement. Often the leptomeningeal enhancement is best seen on the post-contrast flare image, which is here on the right. This patient also has hydrocephalus, which is a common complication anytime you have a meningitis, whether it's related to sarcoid or whether it's infectious meningitis. Anytime either one can cause hydrocephalus due to obstruction to the resorption of CSF. This is another patient, extensive leptomeningeal enhancement along the basal cisterns. Again, the patient has hydrocephalus. This patient does not have sarcoid, however. This patient has tuberculous meningitis, so they can look quite similar. I just want to show this. This is also a patient with sarcoid. It can involve the bones, so you can have involvement of the vertebrae. It's not very common, but the CT on the left, we can see sclerotic lesions in several vertebrae. Kind of looks like the same thing you might see with sclerotic metastases. Here's the T1 low signal in multiple lumbar vertebrae. After contrast, the dark areas enhance. Here's the, on the right is the stir image. Really looks like vertebral metastases. Form of the follow-up after treatment with steroids, and if you compare on the left, I have the two T1 weighted images. You can see the areas that were dark here now have more fatty marrow. So you can see that dark is now reverted to more fatty marrow. The next two slices, the enhancement has resolved, and the stir hyperintensity has mostly gone away also. So not common, but when it presents, it can be virtually indistinguishable from vertebral metastases. 47-year-old woman, loss of vision and diplopia. So for contrast-enhanced T1 weighted images, and this shows extensive pachymeningeal enhancement. You can see very extensive all along the meninges, along the tentorium here. Fairly uniform, although it's not completely uniform. There's an area here that does not have any enhancement, but is fairly extensive. Same thing on the coronals, extensive pachymeningeal enhancement. Dural biopsy here showed IgG4 positive plasma cells, and a follow-up after steroid therapy showed that virtually all of that pachymeningeal or dural enhancement had resolved. So IgG4 related disease, the most common finding intracranially is pachymeningeal enhancement. Some cases of orbital pseudotumor will be IgG4 related disease. Outside of the brain, it also can involve the lacrimal glands and salivary glands. This patient with IgG4 with enlarged lacrimal and submandibular glands. Just to contrast, this is a 40-year-old woman with postural headache, which is quite similar to the patient I showed with IgG4. This one is extremely uniform. And in this case, it was due to intracranial hypotension. Next case, 31-year-old woman with lupus. This is her initial MRI, 2018. Shows a small lesion in the left basal ganglia, not too impressive. That was in September 2018. She had a follow-up a couple of months later. Some new lesions, a lesion here in the right basal ganglia. Really looks like a lacunar infarct, although it did not have restricted diffusion. Another lesion in the cerebellum. Came back a little bit later with some lesions in the pons. Again, this one here looks like an old lacunar infarct. We have on the diffusion images here, just this lesion showed restricted diffusion. So this lesion was an acute infarct. The other lesions look like older infarcts. So just to talk a little bit about lupus, the most common findings intracranially are infarcts. These can be large or small vessel infarcts. They're often associated with antiphospholipid syndrome. And lupus vasculitis, we used to think that was a thing. It may still be, but it's quite rare. So generally, lupus does not cause a vasculitis, fairly uncommonly. Most of the infarcts that we see with lupus are due to the clotting problems. So they're mostly related to the hypercoagulability. Vasculitis would be an uncommon cause. Again, we show these infarcts, both acute and chronic infarcts. In this case, we had mostly small vessel type infarcts. Rarely you can get areas of demyelination with lupus, but again, this is quite unusual. So most of the lesions we see in lupus are infarcts. 27-year-old man. This patient has a history of Behcet disease, poorly compliant with the prednisone, 1 month of progressive right-sided weakness and diplopia, ataxia, and somnolence. Had this MRI, flare. The first 3 are flare images. It shows abnormal signal in the pons, midbrain, and thalamus. On the right is a susceptibility weighted image, so a couple areas of microhemorrhage associated with it. Post-contrast, we see some patchy enhancement. And this is a patient with Neuro-Behcet disease. So it's not clear how often neurologic involvement is in Behcet disease. It's probably around 10%, which is about what we see in similar number that we see in sarcoid. But unlike with sarcoid, where the neurologic involvement is often the presenting feature, most of the patients with Neuro-Behcet's disease already have a history of Behcet disease before they present with neurologic symptoms. So what are the imaging features of Neuro-Behcet? So most commonly are the parenchymal abnormalities. So what's characteristic about Behcet is the location of the abnormalities, strong predilection for the brainstem, basal ganglia, and thalami. So these central structures are involved. Patchy contrast enhancement we will frequently see, and we often have small foci of microhemorrhage. There's also a non-parenchymal form of Neuro-Behcet, which consists of dural sinus thrombosis. So you can get venous sinus thrombosis, also secondary to Behcet disease. So here's this patient with that we showed with the lesion in the midbrain and the thalamus. 10 months later, he was readmitted in status epilepticus. It became unresponsive. Now, much more extensive involvement, midbrain, bilateral thalami, only a little bit of enhancement. Again, areas of microhemorrhage bilaterally. 2 months later, after treatment, mostly all resolved. So it's a waxing and waning course, can be difficult to treat, and the patients can be quite seriously ill. Most of the patients, as I said, do have a history of Behcet's, and usually you can get the history of the oral and genital ulcers that are characteristic. Okay, 20-year-old woman, acute loss of vision in the left eye. So we have a CT, shows extensive sinus disease, opacification of the right maxillary sinus, both ethmoid sinuses, as well as some opacification in the upper nasal cavity. If we look carefully on the soft tissue windows, it looks like there's some intracranial extension here. And the bone here does not look so healthy. It looks a little bit, maybe slightly eroded there. Here was the MRI. A lot of enhancement in the sinuses. You can see the enhancement extending intracranially here. It didn't really add that much to the CT. I think initially a biopsy was done. I think it was non-diagnostic. Biopsy showed some granulomatous inflammation. The patient was treated with antibiotics and steroids. Returned 2 months later with fever and headache. And here's a T2 weighted image. And on the coronal, we can see there's still a lot of disease in the upper nasal cavity and ethmoid sinuses, and maybe a little more pronounced intracranial extension here. This one is low signal on T2 weighted images. There's some edema now in the adjacent frontal lobe. Post-contrast, we see pachymeningeal or dural enhancement here. So this pachymeningeal enhancement. You can see it also on the axial images. Again, some more dural enhancement further up. Another biopsy was done, and this second biopsy showed necrotizing granulomas with polyangiitis. So this is a case of granulomatosis with polyangiitis, used to be called Wegener's. These patients who have intracranial involvement, it's usually secondary to extension from adjacent sinus disease. So it's uncommon to have primary brain involvement in Wegener's. Usually it starts on the sinuses and extends upward. Next patient, 63-year-old man, altered mental status, hearing loss, and branch retinal artery occlusion on a fluorescent angiogram. So here's the brain MRI. These are all FLAIR images. We should see multiple areas of FLAIR hyperintense signal. We can see some in the posterior fossa, in the middle cerebellar peduncles, some in the basal ganglia or internal capsule here, and a bunch here in the corpus callosum. There's also a corpus callosal involvement and some other scattered white matter lesions. So initially, after the MRI was thought to represent MS with these typical periventricular lesions involving the corpus callosum, posterior fossa lesions. So it looks pretty good imaging-wise for MS. A couple of things were a little unusual here. So on the diffusion-weighted images, so we do see some of the lesions have restricted diffusion. Now you can get restricted diffusion with acute MS plaques. This is a sagittal image. You can see the one on the left is before the patient became symptomatic. You can see the corpus callosum initially was normal here, and then after the patient developed symptoms, we see these lesions kind of centered right in the middle of the corpus callosum here. So we had some post-contrast images, and it's a little subtle here, but these little dots you can see in the cerebellum, I think are on the surface of the cerebellum, so you can see little dots here. I believe these are areas of leptomeningeal enhancement. You can see some here. They're like right on the surface of the cerebellum. So these are areas of cerebellar leptomeningeal enhancement. So leptomeningeal enhancement is not at all common with MS. You can see enhancement within the acute plaques, but not leptomeningeal enhancement. So this is a year later after treatment with steroids and rituximab. Pretty good response. A lot of the lesions went away. You still see these lesions in the corpus callosum, and what's interesting, they're centered right in the middle of the corpus callosum, or they extend all the way through, as opposed to being more toward the callosal septal interface. So this is a patient with Susac syndrome, and Susac syndrome is an autoimmune disorder that involves small vessels of the brain, retina, and cochlea. So they present with encephalopathy, brain, hearing loss, cochlea, and vision loss, retina. They don't necessarily have to occur at the same time, so often they may present with one or two of those three findings. The vision loss is secondary to branch retinal artery occlusion. So in this patient, the fluorescent angiogram showed the typical findings of Susac syndrome. So this, for this disease, to diagnose it, the history is extremely helpful. So you like to see at least one of these things, either hearing loss or vision loss. Otherwise, it can be quite difficult. So on imaging, we do see T2 hyperintense lesions, corpus callosum, white matter, and posterior fossa. It's often misdiagnosed as MS because they do look quite a lot like MS, the lesions. So one thing that can distinguish it a little bit from MS, although it's still not easily distinguished, is the location of the corpus callosum lesions. So they tend to be centered in the central portion of the corpus callosum instead of more toward the callosal septal interface. And you may have restricted diffusion or enhancement in acute lesions. Again, it doesn't necessarily distinguish it from MS, although the restricted diffusion is more typical in Susac. Restricted diffusion is actually quite uncommon with MS. Susac is a vasculitis, so the restricted diffusion is more common. And leptomeningeal enhancement is uncommon in MS, but you can see it sometimes in Susac syndrome. Next, 74-year-old man treated with squamous cancer of the tongue base many years ago. Recently developed a recurrent tonsillar cancer, and now after surgery, he came in with lethargy, difficulty walking, and speech and memory problems. And he had initially a CT, shows some hypodensity bilaterally. MRI is much more impressive, and fairly symmetric signal abnormality on FLAIR. So it's the involvement is most pronounced over the convexities involves both the cortex and the white matter. So it's not just white matter involvement, white matter and cortex, fairly symmetric. It also involves the insular regions here, and maybe subtle left hippocampus. Let's see. Diffusion-weighted images don't show any restricted diffusion here. Post-contrast, no enhancement. 3 months later, patient was getting a little worse. The abnormality is maybe a little more extensive. Now I think it's a little more obvious in the medial temporal lobes bilaterally. And the CSF was positive for voltage-gated potassium channel antibodies. So this is a case of autoimmune encephalitis, and there are a lot of different types of autoimmune encephalitis. So they can be paraneoplastic or non-paraneoplastic. So initially we used to think these were generally paraneoplastic, but some are and some aren't. They can be due to antibodies to intracellular antigens or cell surface antigens. There's a whole list of cancers that can cause these. I just have the most common: small cell lung cancer, testicular and ovarian tumors, neuroblastoma, breast, Hodgkin lymphoma, and thymoma are the most common, but it can be associated with many other cancers. So what do we see on imaging? So what's fairly characteristic about the autoimmune encephalitis on MR is that it frequently involves the cortical structures, especially the limbic system. So hippocampi, insular regions are frequently affected. So most of the time there's no enhancement and no restricted diffusion. Sometimes there can be restricted diffusion, but it's usually not prominent. Usually doesn't have significant amount of enhancement in these patients. Interestingly, patients with NMDA receptor encephalitis, which is often associated with ovarian teratomas, The majority of patients with that will have normal brain MRIs, even though they will have altered mental status and can have severe neurologic symptoms. Some of them you'll see a more typical limbic encephalitis pattern, but I think the majority of them will have a normal brain MRI. There's another patient with autoimmune encephalitis. This one is a more typical limbic pattern encephalitis with bilateral hippocampal involvement. Also a little bit of involvement in the thalami here. Next, a 46-year-old woman, episodic severe headaches, blurry vision. Initially started after an intense workout. She had an abnormal MRA at an outside hospital and was transferred to Georgetown. The brain MRI was not that impressive. Just a few dots in the white matter, yeah, fairly unimpressive. But she had a report of an outside abnormal MRA. So she underwent a cerebral angiogram, and the cerebral angiogram was abnormal, and it's the abnormalities we can see a little better on some magnified views. I have some arrows on it, so you can see multiple vessels have areas of abnormal narrowing and dilatation. Narrowing, dilatation. So this is what we'd call a beaded appearance, where you have sequential areas of narrowing and dilatation. Here's another vessel, posterior cerebral branch here that have narrowed areas. And if we look carefully, there are also a number of other vessels that are involved. You can look out here, you can see narrowed and dilated, narrowed. So it's a fairly extensive involvement. This pattern is typical for a cerebral vasculitis. So this was after the initial angiogram. She was treated with steroids. 5 weeks later, she had a follow-up MR angiogram. Still had mild abnormality. You can see the arrow shows a narrowed MCA branch. You can still see a little bit of narrowing in the anterior cerebral artery. Much of it had resolved, but there's still several areas of narrowing. 2 years later, again, almost further improvement. Still has some minimal narrowing here in this right MCA branch, but mostly back to normal. So, CNS vasculitis can be either primary angioitis of the CNS, so CNS vasculitis without any systemic involvement, or you can get CNS involvement secondary to a systemic vasculitis. So granulomatosis with polyangiitis occasionally can have CNS involvement. Of course, we saw a case of earlier of that, where, as I said, most of the time the intracranial involvement is secondary to sinus involvement, but you can have a cerebral vasculitis rarely. Giant cell arteritis can cause a cerebral vasculitis. You can get cerebral vasculitis from infection, varicella zoster virus and fungus. So what do you see on brain imaging? Acute and chronic infarcts, periventricular and subcortical white matter T2 hyperintensities. These are quite nonspecific. You can get hemorrhages, and you can get leptomeningeal enhancement. When you do vascular imaging, you see vessel narrowing, occlusion, and dilatation, and it tends to resolve fairly slowly after treatment. So on angiogram and on MRA and CTA, you can often see this so-called beaded appearance. Unfortunately, this beaded appearance is not, although it's characteristic, it's not specific for CNS vasculitis. You can also see it in reactive cerebral vasoconstriction syndrome, and you can also see it occasionally in intracranial atherosclerosis. If you do vessel wall imaging, you can see segmental vessel wall thickening and circumferential enhancement. So this patient here has vasculitis secondary to mucormycosis, and you can see this circumferential enhancement around the internal carotid. So this was an infectious vasculitis in this patient. And I think this is the final patient here, 35-year-old woman, bilateral leg weakness, falls, and headache for two days. She's 6 weeks postpartum and was diagnosed with lupus shortly after delivery. So here's the brain MRI. Shows a little bit of signal on the left occipital lobe here on the flare. On diffusion, a little bit of bright signal in the white matter bilaterally, but fairly mild appearance, but it was abnormal as a young woman. She had an MRA, and the MRA was extremely abnormal. So I think you see it best on the coronal images. You can see multiple areas of vascular narrowing. Here's a nice beaded appearance, so you get vascular narrowing, dilatation, narrowing, dilatation. So beaded appearance, which you would say would be characteristic for vasculitis, and multiple vessels are involved. Here's the posterior circulation, dilated, narrowed, dilated, very extensive involvement. However, I mentioned earlier, lupus does not often cause a CNS vasculitis. So this patient, 6-week follow-up, totally normal. And vessel wall imaging, there was no vessel wall enhancement. And so this patient did not have a cerebral vasculitis. This patient had reactive cerebral vasoconstrictive syndrome, or RCVS. So with these, the narrowing usually resolves fairly quickly. You get diffuse vessel wall thickening, but if you do vessel wall imaging, you get little to no vessel wall enhancement. So in this patient, the RCVS was due to the postpartum state. There's some overlap between RCVS and PRESS, so it was likely related to being postpartum and not related to the fact that she was diagnosed with lupus. Okay, so we talked about a number of different diseases, and I want to thank you for your attention.